Oh yeah, the slides up.
Yep, I can see the slides.
Yeah.
So, hopefully most people are sorted. Most people seem to have managed to get, or are in the process of getting the audio. So, I'm just going to check. Can you see the slides?
Yep, I can see the slides.
Yeah.
Brilliant. So, at the moment I can't actually move the slides. It will work. So I'm going to have to go off this screen. If you can speak, obviously just chip in with questions. Really what the purpose of this WebEx was just to bring everyone together to see if there are any issues people have, and to just remind everyone right back to the beginning of why we started the virtual clinic, and you know, the different roles people play within them. So my name's Helen Williams. I am the clinical lead for the NCL, the North Central London AS programme at UCL Partners. We also have some of the rest of the UCL team here. So we have Kate St John, who's our project officer, Howard Chowdhury, who is our programme manager, and Satiris Antoniou, who is the North East London clinical lead for the AF programme. So any difficult questions, I'll be passing over to Satiris. So has anyone got any specific issues? Either they can type it, if they can't, if the audio isn't working for them to speak to it, or you can obviously tell us if your audio is working. Any specific issues you want to particularly pick up on today?
No, I'm fairly comfortable with everything.
Let's see if anyone's, let's see who's online. We've got quite a lot of you online now. Just for anyone who's joined late, and if you're having problems with the audio, you won't be able to hear me say this, but I'll type it back in the box, what you have to do to log on. So I'm going to kick off then. If you have questions along the way, you can type them in or say them. And the first thing for me really is to go through the just why we were doing the whole process of the virtual clinic. I'm checking that my slides will move, which they do. If you can't see the slides, let me know. There's sometimes a bit of a lag between me changing them and you guys seeing them on the screen. So the AF Virtual Clinic model came about because we knew there were significant issues with the rate of anticoagulation for patients with AF who are at risk of stroke. We've seen great improvements nationally. So far, nationally, we're up to about 84% anticoag. But there's significant variation locally in North Central and in fact across the whole of London in terms of achievement of the rate of anticoagulation that we're looking for. So at a national level, we're at 84%. That still means 147,000 people not treated. We know that about 20% of strokes are in patients with AF. They cause more. They're more likely to cause death and significant morbidity than a non-AF related stroke, so they're associated with poor outcomes and increased costs. And this virtual clinic model for AF aims to try to ensure that every patient who's not currently anticoagulated in AF receives a formal review by a specialist to assess whether that decision to treat or not treat is appropriate. Are you all still seeing the slides?
Yeah.
Good. So, my slides are moving and then not moving again. These.
Yeah.
So the aim of the virtual clinic model is to bring the specialist skills that we often use in the hospital setting and into general practice. So we could use anticoag pharmacists, which is the model that we're using across North Central London. You could use nurses. You could even use haematologists if you're rich. But clearly, there isn't a huge number of haematologists to spread around, and it's probably not the most efficient way of reducing therapy. So we're using in North Central all anticoag pharmacists, and it's a pretty simple process really. Identify all the patients on the AF register who are not anticoagulated, using a standardised search, then review all of those patients and collect some of the data we need to make clinical decisions. So the CHADS-VASC and the HAS-BLED, treatment today and why the patients aren't anticoagulated, and anything relevant that might affect the decision. So recent hospital admissions, bleeds, all of those things. And then the pharmacist arranges to meet with the GP practice. In some cases it's an individual GP, it might be the practice pharmacist, or it might be the whole practice. And I've done virtual clinics with 14 members of practice staff there. So it depends on how the practice wants to do it. They sit down, discuss each of the patients not treated, make a plan, which might be refer to cardiology for a diagnosis. It might be anticoagulate immediately. It might be refer to haematology for more advice. It might be have another discussion with the patient because they've declined anticoag in the past. Or it might, it could be all sorts of different issues that need to be addressed. And then once the agreement's made between the practice and the pharmacist of what needs to happen next, then the practice should implement those plans. Now, for us, we had an incentive scheme, and in order to pay them the incentive scheme, the GP practices had to submit their outcomes for those patients. Now, NHS England require those outcomes to be submitted, but each CCG in North Central London has a slightly different process for whether patients practices are or aren't incentivised and what that incentive looks like. So just to give you an idea, these are the numbers of patients that the CCG will need to treat over and above where they were in QOF, which unfortunately is data going back to October 2000, data from October 2018, which actually gives us a picture of what was happening at the end of March 2018, so we're nearly 18 months out of date with the data. So these are the figures that each of the CCGs in the programme would need to treat to get to the various targets. So Islington would need to treat another 171 people on the AF register to get to the AHSN target of 84% by March 2020. But we know that beyond that we have a London target to get to 87%. They need to treat 226 patients, and the national ultimate ambition is to get to 90% treatment, and they need to treat 282. So across all the virtual clinics that are happening in Islington, I can't remember how many practices there are. In my head I want to say 27, but I could have made that up. The practices need to identify and treat, I say, another 171 to meet the lower target. Barnet 271. Camden, whoever's here from Camden, you have it easy. You only got to get 72 to get to the target. But we shouldn't use those targets as the be-all and end-all. The aim is to review every patient, make sure every patient has appropriate therapy. These are just a sort of measure, really, is to see if we're moving in that right direction. And nationally, we have CCGs who have 92, 93% of their patients treated. So we know it's entirely possible to get these sorts of numbers. The default position now really is anticoagulate unless you can really persuade yourself not to. The background for the work is some of the work we did in South London, in Lambeth and Southwark, which is one of my other hats, where we rolled out virtual clinics across 91 GP practices over the course of a year, with about 0.6 whole-time equivalent support from specialist anticoag pharmacists from King's. And we saw over 1,500 patients reviewed and over 1,200 patients treated across the two CCGs. Significant improvements in the rate of anticoag, particularly in Southwark, where we embedded a standardised search, which we didn't have for Lambeth. And really, the pharmacists, they did Lambeth first, followed by Southwark. By the time they did Southwark, they'd really, worked out the communication, how to get the GPs engaged, and really how to make things happen. And seeing the increase in anticoag was great, but the really important bit was the reduction in AF-related stroke. So we've seen about a 25% drop since we started the project. We delivered it over the it was delivered in a year, but across the financial year 2015-16, and some of it was in 2014-15, some in 2015-16, and then we started to see the reduction in stroke, which is obviously what we're hoping to achieve for central London with the programme running across the whole STP. What are the advantages of this model? Well, it's an opportunity for specialists to work with primary care directly, update them on best practice, address any myths and misconceptions that they may have about anticoag and particularly the newer agents. Well, to be fair, it's both. People have real fears about warfarin that aren't justified, and similarly concerns about DOACs, and it's important that we present the evidence base for treatment, understand the risks of treatment, put them into context, and address some of the questions people have, like maybe about aspirin and falls and frailty. Hopefully by doing that, we change the behaviour of the frontline practitioners for the long term, and actually what we have seen is another set of data now is year on year a reduction in stroke across Lambeth and Southwark. So although the intervention went in at the end of 2014-15 and beginning of 15-16, there's been a continued reduction in AF-related stroke and an increase year on year actually in the rate of anticoagulation beyond the project. So you could theoretically run this centrally from Birmingham, do every single CCG in the country from a call centre, but actually the bonus of this work of using local practitioners is the opportunity to strengthen the relationships between specialist services and primary care. And as a result of the work we did in Lambeth Southwark, the pharmacists took it upon themselves to redesign the referral form across all three of the local tertiary centres to make the life of the GPs easier, because they saw the GP perspective for the first time. And then we started doing what we call virtual initiations of DOACs. So patients that weren't really suitable for hospital referral for initiating a DOAC, bearing in mind we didn't have a community service for initiation, they would just contact the pharmacist, who would look through the patient record with them, agree a drug, agree a dose, make sure the monitoring was in place, and build up the confidence of the GPs to start the DOACs themselves. Knowing, of course, that they always could ring the pharmacist if anything went wrong. And then, obviously, the other thing we get out of this is quite an in-depth data on the untreated population. So one of the things we're collecting through the NHS England spreadsheet is, are these patients are they housebound? Are they in nursing homes? Because often that's a reason for not anticoagulating, because our services aren't designed around those individuals. They're designed around people who are mobile and can get into the service, and clearly that's an inequality that we need to address if all of our housebound patients are not being anticoagulated because our services aren't suitable. So these are the comments we had from the GPs around the process, that actually they found it useful because it built up their confidence. It changed the way they work in the practice. They were happy and more confident to anticoagulate the higher risk people, because they're the ones that traditionally have not been anticoagulated but have the most to gain from treatment. So we're quite happy to anticoagulate a low risk 60-year-old who might just chip the CHADS-VAS score, but an 85-year-old with multiple risk factors at very significant risk of stroke, we've been much more reticent to treat in the past, and actually would get more out by treating those more high-risk patients. So a lot of the patients we've reviewed in the virtual clinics were those in the late 70s, early 80s, even up to the 90s. Hello? Oh, thought we might have a query then. Oh, now that's gone awry again. What is this? So, from a primary care CCG perspective, the benefits were supporting GPs to make evidence-based decisions about anticoagulating their patients, an educational process, refining the referral process, particularly with the form redesign, promoting a change of behaviour within the frontline staff to ensure the programme was sustained, breaking down the barriers so primary and secondary care work together more effectively, delivering care close to home and reducing unnecessary hospital referrals and affordability. So if every single one of those 1,500 patients had been referred to secondary care at a cost of around £400 or £500 per referral, you can imagine how significant the cost would be to the CCG. By bringing people out and negating the need for referral, there was significant cost savings using this model, but still ensuring optimal treatment and specialist input to care. So, in terms of the elements for delivery, for me there are three that we need. One is funding, which in this programme has come from NHS England, and they've provided funding for the pharmacist, for some kind of GP incentive, and also and actually most of the funding is for this, the additional in-year costs for the DOAC, so the in-year drug costs that result in a cost pressure for the CCG. Personally, I think it needs to be embedded in some kind of GP delivery scheme, or a prescribing improvement scheme, or a meds-op scheme locally to engage the practices and make sure that they are recompensed for the work that they do, particularly in carving out the time for the virtual clinic. Make sure you can find a credible local clinician to support the GP practices. It needs to be someone who can answer the questions they come up with, and has significant experience in managing patients with anticoag, and then providing local resources to GP practices. So we have standardised searches, and in North London the APEL tool that's originated from North East London. Also it's standard unit searches and System 1 searches, audit data collection tool which NHSE have provided, the virtual clinic guide, and the local prescribing guidance to ensure people are aware of what should be happening based on local agreement. So this programme was due to run for 18 months, but because of some delays on the NHSE side, it was meant to start in September 2018 and run to March 2020. They didn't really get the money agreed until the end of 2018. Therefore, we really didn't get started in North Central London until March, April this year, 2019. Although they have given money for 18 months, we still need to ensure that we finish in March 2020. So the money is there to provide 18 months of a pharmacist, but the time frame now requires it delivered by March 2020, so you might want to double up the time of the pharmacist or get additional sourcing if you won't finish, including the GPs delivering the outcomes by March 2020, which means the actual virtual clinics need to have been delivered ideally by the end of December. The original deadline was the end of November, certainly by the end of January, because there needs to be time to refer the patient into anticoag, get them seen, get them initiated and back into general practice. So we need to make sure that we can deliver to those timescales. There is a risk, of course, that NHS England will take some of that funding back as part of the contract if this wasn't delivered within that time frame. So important to realise that our time frame for delivery is relatively short. I think to build the project into schemes to get the GP engagement and ensure that they are funded for the work that they do. So I think one of the issues and queries that's come back is about the initial audit. The audit data collection has been designed to be minimal. So basically you need the age and gender and ethnicity of the patient and a postcode, and the postcode is used to determine the social index score to assess for deprivation, basically, based on where the patient lives. So that's a standard metric in the NHS for assessing deprivation, which is an important issue for NHS England. Every programme they do now has to look at health inequalities. So really basic patient data, which takes about 20 seconds to collect from the GP system. The CHADS-VASc score. Now, most systems calculate CHADS-VASc automatically but I have a high level of suspicion of the accuracy of that. So I also check CHADS-VASc myself to make sure I agree with the score that EMIS or System 1 or Vision has come up with. So CHADS-VASc is a score based on comorbidities the patient may have. C for congestive heart failure, so patients with LVSD, left ventricular systolic dysfunction, or preserved ejection fraction but have heart failure. Hypertension, diagnosed hypertension. EMIS incorrectly codes patients with consistently raised blood pressures recorded but no diagnosis. It will add them into the hypertension, so you just need to be aware of that. Age over 75, which gives them 2 points rather than the others, which are 1. Diabetes, diabetes mellitus, I should say, which gives them 1 point. Previous stroke or TIA. Now, until very recently, EMIS was also counting anyone who'd had a previous DVT and PD. There are a lot of people who've been overscored on that indicator, which is 2 points. So anyone who was young with AF and had a DVT in the past automatically have scored 2 based on the EMIS scoring. So those need to be reviewed because that's incomplete. Patients with vascular disease, that is defined as prior MI, aortic plaque, and they're unlikely to know about that unless they've had scans, so known aortic plaque, and peripheral vascular disease. So those are the 3 vascular things that count for CHADS-VASc, and they get a point. Age over 65 gets a point, as opposed to over 75, which gets 2. And sex category, which is being female. So if your only point is for being female, it doesn't count, but it's an additive point. So if you've got any of the others and you're female, you would get an extra point for that. So important people understand the CHADS-VASc score and can just double check that the CHADS-VASc has been calculated correctly, because the system does have anomalies that have crept in over time. And certainly when I've been doing some of the virtual clinics alongside people in North Central London, we found that Apple Tool gives 1 score, AMIS gives another, and so we need to check through to ensure that we're using the correct one. The Hasbled score is not automatically calculated by the system, and the Hasbled score has a big overlap with the others, with the CHADS-VASc. So Hasbled is uncontrolled hypertension, so it's not a diagnosis of hypertension, it's only if the blood pressure systolic is above 160 that you get a point. So clearly to reduce the blood pressure to below 160 gets rid of that point in Hasbled. Abnormal renal or liver function tests, and for that, for renal, it's a creatinine above 200. So, quite significant renal dysfunction. And I'd have to check the liver. I can't remember whether it's 3 times the upper limit. Need to double check that. Prior stroke, TIA. Bleeding tendency, so if they've had bleeds in the past or have some disorder that's going to make them bleed more. Having a labile INR, generally, particularly obvious in patients who have had warfarin in the past. Elderly, so age over 65, gets you a point on Hasbled, and D is interacting drugs. So alcohol gets you 1 point, or drugs relating to that might increase bleeding risk. So I tend to think of the non-steroidals, for example, maybe high-dose steroids, things that are going to increase that risk. So clearly for alcohol, interestingly, you become positive for alcohol when you only drink 8 units a week. So it's not the usual 14 units, and the way to address that bleeding risk is obviously to work with the patient to reduce their alcohol intake. Clearly, if you're anticoagulating patients, you should be stopping, in most cases, the antiplatelet drugs like aspirin, low dose. There was a study out last week at the ESC, which I will track down and send the link to people, which clearly shows that if you left antiplatelets on with full dose AF anticoagulation in stable coronary disease, then there was an increased risk of events. So we should be stopping the antiplatelets. Not sure all cardiologists have got that message. So probably the most complicated bit of the data collection is ensuring CHADS-VASc and Hasbled are done. And then a little summary of the treatment to date. So it might say, was on warfarin, stopped 2 years ago due to bleed, on aspirin, which obviously isn't really treatment, but is what patients are on. And any other reason that might be relevant about why they weren't anticoagulated. So there's different models being implemented around who does the data collection. Could be the GP practice, depending on if they're incentivised. It could be the specialist practitioner. Although because we've got such a short time to deliver the programme, that might not be the best use of their time. It could be local med-soc pharmacists from the CCG, or federation or GP practice-based pharmacists from within the practices. So that has been decided locally, and it's different in each of the 5 North Central London CCGs. And really important that you use the standardised data sheet, the spreadsheet from NHSE to collate all the data. Because at the end of the project, we need to submit all the data to NHS England. It's got what's known as a macro in it. So if you scroll to the far right, there's a big yellow button. And when you press that, it creates a new spreadsheet with none of the patient identifiable data on, which can go to NHSE without worrying about data governance issues. So do make sure you're collating the data on that spreadsheet, because at the end you'll need to supply it, probably centrally to the CCG or to the anticoag specialist pharmacist to collate all the individual practice level data together to then go up to NHS England. At the moment, the only thing we're required to report to NHS England is the number of patients that have been audited, practices that have been audited, so how many practices have had the audit bit at the beginning done, so the patient variables CHADS-VASc has led, and reasons why not anticoagulated. The number of patients the number of practices who've had a virtual clinic delivered, how many patients that equates to. And the next set of data is due at the end of September, so September the 28th, where you'll be required to tell us how many practices have been audited, how many have had a virtual clinic, and how many patients that covers. So, the basics of the search are pretty simple. There's different tools you can use to do it. As you said, we've got the Apple tool. It doesn't necessarily map directly easily onto the NHS England spreadsheet, unfortunately. But it's important that you use the spreadsheet because, as I say, they've got to be collated in the CCG, then at North Central London level, then at England level. So if everyone makes minor adjustments to it, it's clearly going to be impossible to do the data analysis that NHS England will require. Don't change the data spreadsheet, basically. The easiest way to find your patients is actually to go to the AF register and just work through the list one by one and exclude those that turn out to be anticoagulated. But the searches make it slightly more efficient because they should pick out all of the patients that are currently anticoagulated. We do encourage you to look at the CHADS-VASc zeros and ones, mostly because of the problems that we've had with the scoring systems in EMIS. If the CHADS-VASc is definitely 0 or 1, you don't need to collect the detailed data for submission to NHS England. So they're interested in the data for CHADS-VASc 2 or more. But I think at a local level, we're also just compiling the numbers of CHADS-VASc zeros and ones, aren't we? So practically, most practices will have up to 20 patients, although with the practice mergers that have been going on, I know there are some that are very big. And for those that have, 60, 70, 80 patients, you're not going to be able to do that in a single virtual clinic because everyone will use the will to live, basically. So we usually say aim for a discussion of about 2 hours. You can manage 20 patients in 2 hours once you get split at it. Make sure that you specifically agree the actions in practice, document on the spreadsheet. Thanks. The aim is then for the practice to implement the action over the next 3 months and then fill in the NHSE spreadsheet. They may need prompting. We may find we need the pharmacist to go back in to actually collate the data. There may be opportunities to do some feedback to practices across localities. So in one of our CCGs, not Lambeth and Southwark, we've rolled out to a few more in South London. We went back to the CCG because the action 6 months later hadn't been done and presented the cases back that they hadn't anticoagulated alongside the risk for that patient and the reason why they should be anticoagulated. And that prompted quite rapid response from the practices, but hopefully we won't get to that point in North Central. But obviously very important to get the practice engaged in it. So the GPs or practice pharmacist, when I say GP practice, I'm referring to any staff within the practice. So it might be the practice pharmacist who is responsible for delivering and collating the data and submitting the outcomes. And then that needs to be submitted on the completed spreadsheet to the CCG or to the pharmacist for collation and then sending up to NHS. And if the practice is an incentive scheme, it's on the basis of that usually that the practice would be paid. And although GP practices sometimes think, it's hard to find the time to do virtual clinics, our experience is once they get used to the concept, they actually really like them because it's all about how they can improve the treatment for their individual patients. So we had quite wide-ranging discussions. The patients are the starting point for the discussions. Firstly, are we convinced the AF diagnosis is correct? Sometimes when you look through the notes, you think, I'm not even sure whether they got a proper AF diagnosis in 1987 when it was first documented, and we haven't actually managed to record an ECG with AF for the past 15 years. So issues about diagnosis and coding, making sure we're using CHADS-VASC and has bled properly, assessing the benefits and risks of anticoags for difficult patients, so dispelling those myths and misconceptions I talked about, how to have the conversation with patients about what the benefits and risks of anticoag are, to help them make their informed decision, and also thinking about the role of the left atrial appendage occlusion device. So if a patient is truly contraindicated to anticoag, it's funded now at NHS England level through specialist commissioning to consider the insertion of one of these devices that sits in the left atrial appendage of the heart and prevents the clots forming. So if a patient is truly contraindicated, I would suggest that needs to be confirmed by haematology. The patient, if they're suitable, you're not going to do this in a 99-year-old, but I particularly remember a 56-year-old who'd had a stroke in the past with AF and subdural hemorrhages of warfarin, and when I saw him in practice, he was not treated at all. His CHADS-VASC was 5, and we were looking at 20, 30 years potentially of him living at risk of stroke, so he went off promptly to have this left atrial appendage occlusion device. They are funded centrally by NHS England, so there should be a service local in North Central London. I don't know whether it's UCLH that do them. We can check who does them locally, but they're definitely funded. And, we found about 10 patients in Lambeth and Southwark requiring referral for a left atrial appendage occlusion device. So, set some criteria for who the specialist practitioner would be. This was really just to encourage people to ensure they were getting the right type of pharmacist to do the work, who were happy to make the complex decisions that were necessary, but also who would have access to a haematology team they could go back to. They didn't know the answer themselves, to discuss it as a multidisciplinary team and get a plan for those individual patients. And in some cases, the plan might be we're not anticoagulating, and you've then avoided a referral to have that discussion in the hospital. So it's useful to have that bridge between primary and secondary care. And the individual needs to be confident because they're often challenging quite strongly held views of GPs for many years when we were advocating aspirin first line and, we only really gave warfarin to, cases where we thought it was super safe, they were never going to bleed, but probably actually didn't need as much as many of the ones we used to not treat. So it's overcoming those barriers. In terms of logistics, ideally there'll be admin support to oversee the bookings because there can be quite a lot to and fro with practices and it's not the best use of your anticoag specialist pharmacist time to be spending, doing that liaising. You want to ensure the specialist pharmacist, that's a relatively expensive commodity, is used mostly delivering virtual clinics and having face-to-face time with GPs. Obviously, because most of these posts aren't full-time, there's going to be logistical issues around the availability. You might have a central NHS email set up to make sure you don't lose any of those bookings, and making sure there's still time to follow up and deliver the outcomes. There's no point in doing a clinic on the 29th of March next year, virtual clinics. The GP practice isn't going to have time to action and deliver the outcomes by the end of March when the data is required by NHS. And hopefully you will get the same advantages that we've seen in our locality, so opportunities to do more in protected learning time events, meet with locality and federations to support the education, and obviously we're keen to make sure that GP practice-based pharmacists are really central to this. They can't be the only person in the practice who knows anything about anticoag though, because patients are always going to have multiple comorbidities and see other practitioners. So it's important that we train the broader practice team as well as our pharmacists who are already pretty skilled in managing complex medicines issues. Thinking about how the housebound and those in nursing homes are managed, and we have reviewed most of our housebound patients now off warfarin onto DOACs to free up district nursing time. Making sure the pathway works, so there's no delays from referral to treatment. So NICE say less than 2 weeks. At London level, we set an ambition for that to be less than 1 week. And I think we're seeing more and more initiation of anticoag in general practice. Sorting out the quality and safety of anticoag prescribing. So again, we've gone and done a quality and safety audit in Southwark and reviewed prescribing. Have a lot of data from that and supporting patients with adherence. So that's sort of an overview of the process for the virtual clinics, and each of you, I know there's a range of people dialed in today, CCG from practices, from the specialist side. Each of you will have a slightly different role in the process, but hopefully you have a good understanding now of the overall program, the scheme, what it's aiming to achieve, and that will assist you in your parts of the process in terms of delivery. Now, I think that's all I'm going to present, because I feel like I've rambled on for ages. It took longer than I thought. I had a query from someone about resources. So we have a centralised resource database and how I can send out. We've got everyone's email, haven't we? Who's logged on? Who's signed up? Who's signed up to this in advance? Webinar. Yeah. So we can send everyone the resources we have. What we haven't captured, and I was meant to do it at the beginning, is where everyone is from. So I know we've got EY from Camden, and not everyone can speak to me. I know that. There's a little chat box, so if you can just, in case we don't know all of you, pop where you're from in the message box. We've got Haringey, Murat, and
I'm Haringey as well.
So we'll capture all of those so that we know whether we've got the coverage. So I think, I'm just trying to see the names again. Was it Dinesh asked about the resources? We'll make sure we send out the link. So yeah, we've got quite right. Haringey, Enfield, and Barnet. Haven't seen so far actually in Islington. But to be fair to Islington, I did see the specialist pharmacist from Islington yesterday, and she's actually got most of her practices booked in and will be delivered within the next 4 to 6 weeks. So they're a bit further ahead, I think, in terms of delivery. It's a smaller CCG, so fewer practices to visit. So going well there. Any queries people have, either type them into the box, or if you have the opportunity to speak to us through the mic, then do ask. any issues I haven't dealt with, concerns, issues that have come up in implementation. You're all very quiet. I think we've got quite a few practice pharmacists here, maybe involved in supporting the data collection, and that's really important that spreadsheet is designed when we collect the data that most of the information we need for the discussion is captured on there. It's small, it's simple, and short little bits of information, but it really informs the discussion with the GPs, the virtual clinic, or the practice pharmacist. Virtual. So it's really an important element. So I'm not getting any questions coming through. I'm hoping you're all feeling inspired to deliver the programme. If you have issues or concerns and need support, then obviously there may be local people you can get support from. The anticoag specialist may be able to support, but there's also Kate and Howard at UCL Partners and myself who can offer additional support if you have issues or concerns or clinical stuff comes up in practice. I can help address that. One of the things we've done with the specialist pharmacists is set them up a little WhatsApp group, so they're exchanging ideas, and if they've got difficult patients or concerns about anything, they're sort of supporting each other. We can offer some additional support, any issues that crop up during the delivery of the programme. So in the absence of any major questions from anyone, I suggest we sign off. Do get in touch with us if you have specific queries. We'll ping out some of the resources that I talked about today so that you have them to look through. And hopefully we'll see you again. We've got 2 training events coming up around cardiovascular disease prevention in primary care. If you haven't had the links to those or want to know about them, again, ping us an email. Also in October, we have an educational event around the initiation and monitoring of DOACs, so looking at the safety issues and the things you need to take into consider for initiation. So if you want details of any of those training events, let us know by email and we will send out the invitation. And hopefully we will see some of you there. So thanks for dialing in, and I'm sure we will run into each other again in future.
Thank you very much.
Thanks a lot. Thank you.
Thank you.